Okay, so this is about Parkinson's dementia and Lewy body dementia. Whoops, bless you. So first off, what we know about Parkinson's dementia is that it's a chronic progressive movement disorder. And, you know, the primary signs that we see of this are really the slowing down of movement, the rigidity, stiffness of the limbs, impaired balance and coordination, and maybe tremor of hands and arms and legs, the face, but not always tremors, okay? This is the part of the brain that's affected by Parkinson's. So in Parkinson's itself, it's right in that midbrain, and it's where the dopamine neurons originate, but they don't get to go anywhere because of a protein that comes out of nowhere and just kind of wipes out those dopamine neurons. And that's what causes the whole Parkinson's disease. But the important thing is that like a lot of these diseases, not everyone is the same with the disease. So again, you know, not all Parkinson's patients shake or have tremors. And they don't all develop dementia. And I think one of the most misleading things for all of us is that when those with Parkinson get that mask that freezes their features so that they really kind of have that blank look on their face, we assume that they have dementia, but many of them do not have dementia at that time. Their face just freezes. And so we have to really be conscious that when we're talking to them and regarding them, that we don't treat them like there's nothing going on there, okay? Those who do develop dementia from Parkinson's, they do so long after the original motor symptoms of Parkinson's have been established, at least 2 years after that. The cognitive features in Parkinson's, so just Parkinson's in of itself has slower thinking with it, okay? So again, it doesn't have to be these folks that get Parkinson's and Parkinson's dementia. Just Parkinson's itself can have that slower thinking. Their executive thinking gets affected by the Parkinson's itself, so they might have more trouble than you or I with planning or organizing, problem solving, the multitasking. And they have a decreased attention and concentration. So a lot of times you'll notice that they kind of look off, and you really have to make them look at you if you need them to follow a series of sequences to get them to concentrate. But for memory, their long-term memory is usually fine. And they might have some short-term memory issues, again, just with straight Parkinson's. But the retrieval of the information takes longer. So we may ask them something, and it's not that they're not recalling it, it's that they're trying to pull it forward. And that has all been slowed down. So again, we might jump to the conclusion that because they're not answering right away and not giving us information right away, that they've got a cognitive deficit. It may just be because it's so slowed down. And usually with cueing, they can recall words. You'll find a lot of times that they have difficulty pulling the language forward. It's not because they've forgotten the words. They haven't lost the words. It's just harder and slower to pull those words out, okay? The biggest thing with Parkinson's is the visual spatial dysfunction. So they really have a very impaired sense of direction or spatial maps, okay? So that's where you'll see a lot of times they might come out of a room into a corridor and they're looking both ways and they're not quite sure where they're supposed to go because their mapping technique in their brain doesn't work quite so well, okay? Again, the severity of cognitive changes in Parkinson's varies from person to person, but these are the domains that are most affected. So, we see in that, again, the executive functioning, their ability to make plans, forming concepts, their attention difficulties. It's difficult to pay attention, particularly when several conversations are going on at once. So if you have a straight Parkinson's patient, and you're trying to get them to do something, it's probably a good idea to ask them to come to either a quiet part of the room if they're in a room with other people, or go into a separate room and really try to make eye contact with them to get them to concentrate, because they're very easily distracted. Slow thinking, it takes much longer and more effort for them to complete tasks. And again, the word finding, the words are not lost, they're just slower to come to the surface. Learning and remembering, organizing info as it comes in is really challenging for someone with Parkinson's, because that part of the executive functioning isn't working real well. And again, the imagery and the spatial processes. So for them to visualize, how we'll say to each other, yeah, if you go down by Queen Anne's Corner, in Queen Anne's Corner where Strawberry Fair is, and all of us can get a picture of that. Someone with Parkinson's, even if they're very familiar with the area, can't pull that picture up. Okay, it's that road map, trying to pull that road map up. They might eventually get it, but it's so much longer for them to be able to pull that up and visualize those sorts of things. So if we looked at the levels of Parkinson's cognitive changes, the least severe is in the disease itself, the very beginning of the Parkinson's process, where it's just a slow thought process, so bradyphrenia, and it's very common with movement disorders. And then we have mild cognitive impairment, okay? And we all know that mild cognitive impairment is more problematic with some executive functioning, but it does not impair our ability to function day-to-day life. Okay, so we can still do all our daily tasks, and we can live independently with mild cognitive impairment. Of course, the more severe and most severe are the different types of dementia that someone with Parkinson's disease can get. So if we look at cognitive impairment versus dementia, the same brain changes that lead to motor symptoms can also slow the memory and thinking. So again, that's bradyphrenia, the very onset of a cognitive impairment. But cognitive impairment can affect several different mental skills and activities. And if it's just mild cognitive impairment, it's not typically interfering with their ability to function at home or at work. So a lot of people still work with MCI. When we get to dementia, that's a decline in multiple mental abilities. So it includes memory, but it's a group of multiple mental abilities that impair one's ability to care for oneself and to function independently. So that's how they define dementia. And as we know, that's an umbrella term. Dementia. A lot of people will say to me, my doctor said I have dementia. And I always say, what kind? Well, no, he just said I had dementia. That would be like us going into the doctor and the doctor saying, you have a fever, and we all leave the doctor's office not knowing why we have a fever. Dementia is synonymous with fever. It's a symptom. And so we want to know what type of dementia. So when we have someone with Parkinson's and we're trying to determine these cognitive changes due to dementia, we try to rule out a lot of other things. Is there a vitamin B12 deficiency? Is there depression, which kind of goes hand in hand with Parkinson's? Are there sleep disturbances that could be causing cognitive changes? Anybody who's ever had babies and been up all night, you know what those sleep deprivations can do to your brain, right? Is the cognitive impairment occurring in more than one cognitive domain? Okay, so In Parkinson's, the most common is, again, the visual spatial, but are there other domains that are being affected, like, okay, the attention and the executive, but is memory being affected? Language typically does not become an issue with Parkinson's dementia until well into the disease. Now, that may seem contradictory when we're talking to someone with Parkinson's dementia, but remembering again that if we can cue them and they can pull the words up, they still have their language abilities. Again, it's just slower coming to the surface. There's different studies about what percentage of people with Parkinson's will develop Parkinson's dementia. The numbers are all over the board. So, I'm saying roughly 50%. Some studies have it less, some studies have it more. So, safe bet to say maybe 50%. But not everyone who gets Parkinson's will get Parkinson's dementia. So, here are some of the common symptoms for Parkinson's dementia. It's a decline in thinking and reasoning. Okay, so again, the concentration factor is much more severe than with normal Parkinson's. Judgment, very off. Memory issues, which again, with regular Parkinson's isn't a problem. Okay. Definite problems and trouble interpreting visual information. Okay. And on top of that, they have visual hallucinations and delusions. And their delusions particularly go in the area of paranoia. Okay? So their visual hallucinations, so this is where we get into, well, Alzheimer's people can have visual hallucinations as well. But typically with Alzheimer's, it's a little bit further into the disease. Okay? The hallucinations for Parkinson's dementia is usually a little bit more in the beginning, and it kind of stays with them for quite a bit. Okay? Parkinson's dementia also has a lot of depression, irritability, anxiety, the muffled speech. So now we know with Parkinson's that they get that soft voice speech, which, when we have two speech therapists here who are terrific, and they can do the loud program where they teach them how to project their voice. It's not a problem with the vocal cords, really. It's more a problem with them being able to project their sound from the vocal cords. But with Parkinson's dementia, the speech becomes very muffled. Okay, so it's more like a mumbling. So it's not just the volume, but now it's also being articulate. Their sleep disturbances for Parkinson's dementia includes a great deal of daytime drowsiness. Okay, so they tend to sleep a lot during the day, and then they have that REM sleep disorder during the night. Okay? So Parkinson's dementia typically develops at least 2 years after a diagnosis of Parkinson's disease. Okay? And one of the things that you really want to try to rule out is Lewy bodies, which has a lot of similarities to Parkinson's dementia. Okay? So when you're trying to get a diagnosis of Parkinson's dementia, first of all, I always tell people, go to a neurologist who specializes in this. I'm always amazed by the number of people who, number one, are willing to take a primary care doctor as their only sole diagnostician, which, all due respect to primary care doctors, they don't specialize in these neurological disorders. So you want to get a good neurologist who does specialize in it, particularly Parkinson's or a movement disorder, and go from there. So the diagnosis would include looking at what type of decline we've had prior to the onset of disease up to now where we are. And are the deficits severe enough to impair their daily life, independent of motor symptoms? So their motor symptoms might impair things, okay? But are there other things? Again, the bad judgment, perhaps, the getting lost, the lack of memory, being able to know where they live, that sort of thing. And then we want to exclude other dementias. So you can get Parkinson's with Alzheimer's, or you can get Lewy body's dementia. Okay, so that we want to rule out all those other things. And those are really done a lot from the PET scans and the MRIs. They can tell those differences. But, the first thing we do is that mini mental. Has anybody ever seen a mini mental test? Any of you guys? They are, they're so humiliating. They're really an awful test. So look at these things here. So somebody comes into a doctor's office and they're being asked to, count backwards from 7, starting at 100. Now you're nervous and you're in the doctor's office and you're supposed to start counting backwards by 7. I couldn't do it. Okay? Say your months backwards. So these tests are not, they're really painful for these folks. And you hope that they take into account the stress level that these poor souls feel when they're doing these tests. There is 2 doctors who recently published something about a new type of test they're trying to come up with that's much more compassionate towards that whole nervousness of having to do these tests. So then they look at like the clock drawing. Now the clock drawing is pretty indicative of Alzheimer's. If you see that clock, basically what they say is we want you to draw a clock and put the hands at 10 past 11. And you'll see people write all the numbers down one side of the clock and they circle the 11 and the 10. That's a sign of Alzheimer's, okay? What's really indicative of the Parkinson's dementia is they take those pentagons and so there's a drawing on the test of the pentagons intersecting, and they tell them to copy the intersecting pentagons. And someone with Parkinson's dementia has great difficulty, if not impossible, to copy the drawing. They really can't copy that. That's much more indicative, I think, than making these poor souls count backwards. I mean, that, again, I would flunk it. When the 3-word recall, have you ever tried to do that 3-word recall test? When my mother was being tested for Alzheimer's, they gave her the 3 words, and I sat there through the rest of the testing, repeating the 3 words over and over in my head in case they asked me. So I thought, I'm not going to remember this. Yeah. And then she looked at me when it was time, and I was like trying to look away and everything. So because she wanted me to give them to her. That's hard to do. Again, the nervousness of it. So, with the mini mental, a score below 26 shows there's an impairment. There's the Montreal Cognitive Test. They call it the MoCA. That's a little bit more compassionate than the mini mental. They look at additional features, like is there a report of apathy, depression. Apathy is a big thing that we get with Parkinson's, that people say, he just doesn't seem interested in anything. Well, if he's got that facial freezing, we don't know that he's interested or not, because they can't express it visually. And we're all such a visual world, right? So we need to really measure, is this apathy or is it just what's happening to this person? Depression, delusions, and again, the excessive daytime sleepiness. So here's the differentiators. Parkinson's affects males predominantly, the Parkinson's dementia, as does Lewy body dementia, although I know women with both. But it's predominantly more men.
Why?
That's a good question. I don't know. I don't know why. To me, it's almost like, is there some sort of environmental cause for it? Because they don't know what causes Parkinson's. But I will tell you that the government has acknowledged Parkinson's and ALS for Vietnam veterans who were exposed to Agent Orange. So that tells me that there's got to be some sort of environmental component, right? You know, so maybe that's why men are more affected. Maybe they're out among pesticides or whatever, you know, doing lawn work or, you know, in golf and all that sort of stuff. I don't know why. So that's just a guess, very unscientific guess on my part. It's nearly identical to Lewy body in all the clinical features, but Parkinson's dementia has more postural instability and Lewy body is more spasticity. Okay? But here's where the big difference is. The onset of the movement disorder tells you whether it's Parkinson's dementia or Lewy body. So for Parkinson's dementia, you had to have had the motor symptoms occur at least 2 years prior to the cognitive. Okay? Lewy body, it's just the opposite. The cognitive issues begin before the motor symptoms appear. So Lewy body just happens to have Parkinsonian-like physical symptoms that occur after the cognitive. So that's really the onset of the movement disorder is what tells you what type of dementia. Parkinson's disease dementia has more visual and auditory hallucinations than Alzheimer's, greater falls, a greater degree of depression, and more sleep disturbances. So this chart here is a good way to look at the 3 types of dementia there and the different features of the dementia and how they measure up against each other. Okay? So really, what are the prominent cognitive symptoms with these 3 dementias? You know, with Alzheimer's, it's mostly what we see with Alzheimer's for the most part is memory. That's kind of the first thing that jumps out at us, okay? And very often early on, their language. With Parkinson's dementia, it's more the attention and the executive functioning, and again, that visual spatial function, okay? Which is the exact same thing with dementia with Lewy bodies. All right? The Parkinsonian movement disorder all the time with Parkinson's dementia, rarely with Alzheimer's dementia, and maybe with dementia with Lewy bodies, but I'd say more than maybe with that. Visual hallucinations, you don't get a whole lot with the Alzheimer's. It's just more temporary for a period of time. Very common in Lewy bodies and somewhat common with the Parkinson's. And that fluctuation of the cognitive impairment. What they mean by that is, you know, folks with Alzheimer's, as the disease progresses, they don't come back and all of a sudden perform something great. You know, they may do, like we may get a window, but it's not unusual for people with Parkinson's dementia and Lewy body dementia to have a normal conversation with you even when they're well into the disease. They can carry on fairly well. So the memory loss may be less prominent in the Parkinson's dementia than it is in Alzheimer's dementia. And for Alzheimer's, we know that in the diagnosis of it, the brain changes in Alzheimer's are found with the plaques and tangles, okay? Now, they may be involved with Parkinson's dementia, and they may be involved with Lewy bodies, but more likely it's that protein, the alpha-synuclein, I probably just mispronounced it, but it's that protein that's more the problem in the brain of those folks. The big memory bank that's most affected in Parkinson's is the procedural memory, okay? And those are all, procedural memories are encoded and all involved in motor control, hence that stiffness, the inability, the freezing. You know, how many times do we see them when they're trying to walk and they just freeze in place and they literally can't get themselves to move? That does not involve the hippocampus. Okay, it's a whole different part of the brain. That's why their memory is typically their cognitive memory is better than someone with Alzheimer's. But just as a moment for a second, does everybody know when they freeze like that and you see them kind of like rocking? You know, a lot of times people with Lewy body will start to lean forward because they're trying to go, and that's when they fall a lot. If you start marching in place and get them to march in place, they will eventually start to walk. So it's a simple little trick to get them to get their legs to move. The procedural memory, that's things that work on an unconscious level, okay? It's habit memory. It's like you haven't ridden a bike in, 10 years, you pick it up, you know how to ride a bike, right? You know how to tie a shoe. You know how to drive a stick shift, okay? All those things that it's just habit memory. That's what's affected the most in Parkinson's. So all of a sudden, they can't tie their shoes, okay? They can't sometimes drive. And so it's really, when they get diagnosed with that, that's when you get them off the road right away, because their ability to forget how to operate that car while they're operating it versus plus the visual spatial deficit, where they're going to get lost because they can't visually figure out where to go. That's danger, danger. And yet we hear all the time people with Alzheimer's who haven't driven in years and they jump in someone's car and take off, right? And they can drive it, right? Or they jump on a bike. I heard about a guy who hadn't ridden a bike in like 20 years, and he saw a bike and jumped on it and went down the street. All the kids were chasing him and everything, and he had Alzheimer's. He had a heck of a ride, but exactly. I'd applaud the man. So as far as treatment for Parkinson's dementia, the only FDA-approved medication for the dementia piece of it is the Exelon, the Exelon patch. And a lot of people who are on Exelon also, it's used for Alzheimer's because Aricept may not be tolerated by a lot of people. It's got a GI side effect. So if that's the case, they get switched over to Exelon. Now, I know people with Parkinson's dementia who are on Aricept, so it's kind of surprising that they are instead of the Exelon, since that seems to be the only one approved by the FDA. But here's where it gets into trouble. When people say, well, why is it important for me to know what type of dementia my loved one has? Because when we have to use medications for behavioral issues, what we would use in Alzheimer's is not what we would use in Parkinson's dementia or Lewy body dementia. If anything, some of the antipsychotic drugs that we use in someone with Alzheimer's will do the total opposite for that Lewy body person and enhance all their negative symptoms. So we really want to be careful with that. Also, if they're on a prescription for L-Dopa with Parkinson's, you want to be dealing with somebody, a neurologist, who really knows how to give a medication that's not going to aggravate that when they're trying to deal with the hallucinations and the confusion on top of that, okay? Again, antidepressants, need to be very careful with these drugs. And, what they prescribe for the REM sleep disorder, that needs to be very carefully monitored for these folks. Because, folks with Alzheimer's, it's not a REM sleep disorder, but they'll wake up because they'll get confused night and day. So that's a different thing. So again, if you know what you're dealing with, you can kind of go down certain pathways for treatment. Some of the non-pharmacological approaches would be speech therapy, again, is great, not only for helping them get volume in their voice, which, uh, when I've talked to caregivers and spouses of folks with Parkinson's, that's the number one thing that bothers them is the volume, that they can't hear their spouse talk. And a lot of them feel it's very deliberate, and it's not. I love when these poor souls say, I know he's not talking loudly, so I have to come back in the room and, the whole bit. It's really that they're not even conscious of it. So the speech therapy can be enormously helpful in that way. But speech therapists also work with the cognitive linguistics for folks with Parkinson's dementia, much like they do with folks with strokes. And they can do, word searches and reading comprehension and tests like that will help them with their cognitive issues. Exercise, as we know, is great for people with Parkinson's dementia. Number one, just to keep them safe and keep them moving and keep them a little bit loose, but it also can improve their measures of cognition. And they've done a lot of research with the boxing, with that, when they've tested their cognition after going to boxing classes, the cognition goes up. So does everybody know about this Rock Steady boxing program? So there's this great guy, Brett Miller, who has a studio over it's in Weymouth, it's in Rockland, right on the Rockland-Weymouth line. So behind the industrial park over there.
Yeah, Stratford Street.
Yes. Yep. And so he's over there, and his fitness place is called 110 Fitness. If you ever get an opportunity to drop in there, it's unbelievable. He built this whole boxing ring, this like professional boxing ring where you got to get up into the ring and everything. And he's got all the bags hanging and all sorts of equipment there. And folks with Parkinson's box, and it helps them improve their balance and coordination. I watched his class and I was blown away by it. For one, I was exhausted just watching these guys. They work out for an hour and a half. And they do they do stretching, they do breathing exercises in the beginning, then they do all this boxing stuff. And they go from station to station. They do the tall bags and then the big bags. I know nothing about what the names of these bags are, but they're punching away. And then they go in the ring, and then he does this thing where he dodges back and forth, and they hit to the sides of his head. Very trusting man. And even people who don't have a good sense of balance, they have these volunteers that work there, and they have belts around these folks, and they hold them up with the belts so they can do it standing up. He also has a class for those who are in wheelchairs. So it's incredible, the science behind the boxing and how it improves their sense of balance and also improves their measures of cognition. And so he has this program there that's great. And as a matter of fact, I was so enthralled with it that I went over and said, how can I get involved? And I'm now doing a monthly caregiver support group for the spouses of the people while they're in class. The spouses all come into another room and we have a support group. And it's awesome. And these spouses are just fabulous individuals. 110 Fitness is the name of his club, but it's just great. So again, and he's the type of guy that if you stop by and said, could I just watch? Oh, he'd love it. He'd love it because it's just such a great program. But it also gives all these people this socialism, the social activities that they so need. And again, for Parkinson's, like all the dementias, people retreat because they don't know what to do. And that's the other thing that spouses say, my friends don't come around anymore. So this type of thing, Brett has set this gym up so that the spouses, when they come, he's got a room upstairs that they can all go up and sit and have coffee and pastries and whatever. And then again, once a month, they're going to meet with me. It's great. And then he does, at the end of the class, he does kind of like some yoga exercises and breathing. So now he's also teaching them, he's got yoga classes there for them and Tai Chi. I mean, just everything there. So what are the similarities between Parkinson's, dementia, and Lewy body? They're both diseases that affect the nerve cells in the brain, okay? They're chronic progressive diseases. They affect patients over many years, okay? So the symptoms become more and more apparent over time. There's no cure, sadly, but many medications are available to reduce and manage the symptoms. I think the biggest problems for folks with Parkinson's dementia and Lewy body dementia is that nighttime issue, the REM sleep disorder. That's really tough. There's no single way to diagnose either of these diseases, but they do go through a series of tests to rule out all other conditions. And then again, when they see that protein formation in their test, they usually can put 2 and 2 together from that. And it's really kind of a younger disease. People are diagnosed around the age of 60, which is interesting. So Lewy bodies, what the heck are Lewy bodies? Well, they're abnormally folded proteins found in the nerve cells. How they get there, no idea. How did they become abnormally folded? No idea. That's the frustrating part of this. They're always found in Lewy bodies. They may or may not exist in Alzheimer's and or Parkinson's dementia, okay? If you were to do an autopsy of the brain of someone with Alzheimer's and the brain of someone with Lewy body, the hippocampus has shrunken tremendously in someone with Alzheimer's. Lewy body, not. Doesn't have that atrophy, okay? So that's why you can have these conversations. I spoke with one gentleman with Lewy body. He told me all about his hallucinations that he has, very aware that he sees things that his wife does not, very reasonable in talking to him. You could not have a conversation like that with someone with Alzheimer's who had had a hallucination. For one, they may not remember the hallucination, and for two, they couldn't articulate what it was about. Their dementia hallmarks for Lewy body dementia are cognitively extreme swings between alertness and confusion. They can come off as very drowsy a lot of the time. Again, that reduced attention span, the visual tracking issues. They have a lot of problems with decision making, the organizing, the planning. In judging and navigating distances. That's another thing with Lewy body is that they really can't sense where a step is, how far they need to walk to something. They have issues with verbal and motor initiation. So again, they may appear to be frozen because you'll say, come on over here, and they'll just kind of stand there. And it's not necessarily that they're frozen. They just don't know how to get from here to there. And so you have to kind of cue them to actually move. And they have increased challenges with daily living tasks. They usually do a little bit better than folks with Alzheimer's, but it does catch up with them as well. So their visual hallucinations and delusions occur early on in the disease versus somebody with Alzheimer's, okay? And they may not be frightened. When I talked to this gentleman about what he sees, I asked him if he was frightened by it, and he said, no. He says, I kind of like them. They're little things, and so they're not scared by them. Their delusions might be that they'll have conversations with people who are deceased, okay? Or they suspect that, yeah, you're you, but you're not really you. Someone else has kind of taken over you. So it's really out there. I had one gentleman who thought that God had told him to rewrite the Bible, and that was his delusion, and he stayed with it. That's the other thing with Alzheimer's. They'll have these things happen, and it's a different one all the time. This guy stayed with that delusion, and his wife was so frustrated because he was always like, we got to get home. I got to write, I got to work on the Bible. And so, I finally said to her, have stacks of paper wherever you go so he can just take and start writing, and that seemed to help him out a bit. Lewy body, like Parkinson's dementia, has a lot of drowsiness. They're very lethargic during the day. All of us this time of day get tired, right? But they can get up at 8 and be exhausted by 10. They have a great deal of depression and anxiety. All right, a lot of apathy, irritability. You very often just see them staring into space. And their thinking becomes very illogical with Lewy body and unclear. So their REM sleep disorder is a REM sleep behavior disorder with Lewy body, because what happens is they act out their dreams while they're asleep. So that's why we'll hear from a spouse that they got hit during the night, or that their loved one fell out of bed during the night, because they're acting out the dream. And so what's interesting is that their hallucinations during the day when they're awake don't seem to be violent and not frightening, but these things that they're seeing at night are very bad. I don't know. I don't know if it's just that the brain has slowed down. What were you saying? Night terrors, yeah. Why do any of us have? It's probably when the subconscious comes forward. We have all those fears that we have because our brain relaxes. Perhaps that's it. But they do a lot of screaming. Like people will say to me, I don't know what type of dementia my husband has, but he's been falling out of bed a lot. That kind of gives me a sense. Does he scream a lot? Is he shouting? That type of stuff. They too can have that nocturnal confusion where they get up and they'll get fully dressed at 3 a.m. They think it's time for work. And daytime, they'll sleep greater than 2 hours. You kind of have to wake them up because they can be out for a good chunk of the day. So then you have problems with their movement. So they become slowed down and they get stiff. They get that shuffling walk. That's where I see a lot of Lewy body people. I see either walk on their toes a lot, or they're doing this type of shuffling. And you'll see that somewhat with Alzheimer's, the shuffling, but that's usually towards the end of the disease. For these folks, it's more in the beginning of the disease. They're shuffling. They have an abnormal gait. They have a lot of falls with it. And they, too, can also have that lack of facial expression. Okay, not all of them, but they can be prone to that. But they have some other physical problems with it. Their blood pressure can be really off, people with Lewy body. And their body temperature can really go out of whack, have abnormal sweating. They have a lot of issues with constipation and incontinence quite a bit. They will get those swallowing issues. And again, the swallowing is more towards the end of the disease for Alzheimer's, but it can happen earlier on with someone with Lewy body. And that's when it's good to get a speech therapist consult in there to help with that. And loss of smell, although again, loss of smell is showing up in a lot of dementias. So what are the things that we can do to help them and also help us in caring for them? They're very big. Lewy body dementia and Parkinson's dementia are very big on maintaining a routine. They like a routine. So Because they're so challenged with the organizational skills, the routine really helps them with those areas. So going into the home and encouraging them to keep things in the same place so they don't misplace them. Now, somebody with Alzheimer's, because of the memory deficit, you can say, always put your keys here. Okay, and tomorrow, God knows where the keys are. But somebody with Parkinson's dementia and Lewy body dementia, you can say that, and they know this is the basket for the keys. So they'll know where to get that stuff, but they need someone to organize them with that and to keep that routine. The other thing for their sake is to only offer help if they ask for it. Now, these are in the beginning stages. Clearly, at the end, we're there to help, but they will do okay with photos. So they'll get that face name association. Again, unlike Alzheimer's, if Alzheimer's people are time traveling backwards and you're showing them a picture of their daughter Sally now, I don't know who this chick is because my daughter Sally's 5. Okay? But for these two diseases, you can use that. Key is getting their attention before asking any questions or trying to get information from them. So really trying to get them to concentrate and keeping it simple for them. And show rather than tell because their language processing is also slowed down. So if you can show it, they can get that better. And don't show and tell at the same time. So it'd be tough for me because I talk with my hands all the time. But if you can give them one thing to pay attention to, they can't multitask well. And always try to make eye contact. If you see them drifting off, try to bring them back to you before you continue. So instead of asking, did anyone call, if you know that they've been expecting a call from their son Paul, saying things like, did Paul call? Because did anyone call is too vague. So trying to be more specific in offering some cueing. If they're trying to talk and they're searching for a word and you've asked them, do you want me to help you find the words? You can say, does the word start with a B? And then all of a sudden, oh, that's it. Okay? Don't finish their sentences. Give them time to complete them themselves. And that's a really hard thing to do when we're there under a time crunch. We're in there trying to get a lot of stuff done in a very brief period of time, and you got to wait and you wait. So it can be really tough. In high school, I went out with a guy who stuttered. I finished all his sentences. That relationship didn't last long. I was so impatient. I was like, okay, just forget it. I'll just finish it. It was terrible. I was so cruel. But so we got to give them time to complete the things themselves, okay? And give them choices instead of open-ended questions. Give them choices, and again, allow them time to think about it and respond. When giving a list of actions, so if you were going to leave them with things that you wanted them to do, tomorrow when you're not there, talk about it first, and then you make a list. And you write that list down, and where's the place you want to keep all your lists? Again, those routine places. Putting reminder notes in prominent places where they choose, this is where I'm always going to look. Okay, that's where we're going to put your things. They do very well with alarms. If you need to have them take their medications at certain times, they'll make that connection. So using a medication dispenser with an alarm can be very helpful. And then these are just some resources. They're all in your handout there, although those slides look so small and you probably can't even, without a magnifying glass, actually look at it. But yeah, I guess you can see it all right. Yeah. Okay. So that's basically Parkinson's dementia and Lewy body dementia. Any questions or?
No, I know in my past, if people had hallucinations, we'd really only treat them if they were frightening.
Right.
If they weren't frightening, we would just leave it be. Is that still the same
Yeah.
thought process?
Yes. Yeah. So if they're not afraid of their hallucinations, yeah, that's absolutely, you just go with it. And, for a lot of these folks, you can say to someone with Lewy body, I'm not seeing that, but I understand that you are. Because they also know that as well.
Ah, okay.
Okay?
Versus like
Someone with Alzheimer's,
They think it's
if
happening.
they think it
Right.
happens, you need
Okay.
to validate, I'm sorry you're afraid by what you're seeing. You're not saying, I don't see it, because it
Right.
doesn't exist. So you can be more rational with someone with Lewy body.